Good morning, CareStream fans. This is Michael Lewis. I'm here to do a presentation on the use of the cone beam CT to identify and detect MB2 canals. So this case came in this morning, 47-year-old female, ASA1, no non-contributory medical history. Patient was referred for tooth number 14. And here we're taking a look at tooth number 14. We can see here what prompted the referral. We can actually see some lucencies developing along the mesiobuccal and distal buccal root. Palatal looks fine, but there is quite a large post inside that tooth. And so the referring dentist asked me to take a look at it and see if there was in fact apical pathology. We went ahead and did sensitivity testing, and there was some slight palpation sensitivity on the buccal aspect of tooth number 14. Percussion was not too much. Yeah, the tooth felt a little different, a little funny, but nothing really in the way of complaints or real pain, just that the tooth had an altered sensation. It felt a little different. Not that unusual to have minimal symptoms in these chronic apical periodontitis cases. Anyway, we went ahead and took a preoperative cone beam CT scan, which I would recommend on any upper molar when you're doing an evaluation. The anatomy in these teeth is quite complex. Oftentimes there's debate whether it is worth it or not worth it to use a CT scan, and in my opinion, it's well worth it to order a CT scan on whenever you're doing any upper molar endo. So let's take a look at the scan. We opened up the scan over here. I'm going to go right to the oblique slicing. I find that view to be the most useful. And when we look at this CT scan, we're just going to run along and move the volume around so we can actually see what's going on. And here you can appreciate there's definitely, when you move over the buccal roots, we can certainly appreciate that lesion over the mesiobuccal root of tooth number 14. And tooth number 15, of course, there's a large chronic apical lucency that I would not have detected without the use of the cone beam CT scan. 15 was not sensitive to percussion. It was not sensitive to palpation. But nevertheless, you can actually see this large apical lucency. And I want to go into a little bit of the discussion regarding why these lucencies develop and how important they are to understand what they mean. So an apical lucency is, oftentimes you'll hear general dentists explain to their patients when you say, look at this lucency, that's the infection. No, that's not really the infection. That's the inflammatory tissue that's responding to the bacteria inside the canal. That chronic apical periodontitis is reactive tissue. So again, we're not treating that area of the tooth. Excuse me. And it's important not to describe that as the infection. That's the body's response to the infection and the bacteria inside the tooth. Studies by Nair show that apical granuloma that's there typically has no bacteria present. Just a side note, it's important not to explain that as the infection, but rather it's an indicator of infection inside the tooth. And the first question the referring doctor asked me is, hey, I did that root canal a while ago. Why did the tooth fail? So this video today is really going to try to go through the reasons why root canals fail and understand that root canal therapy is not an easy thing to do. It's actually quite complex and requires a fair degree of expertise, which is why God invented specialists. All right, so let's go through the volume again, and let's take a look at the mesiobuccal root of number 14. We're going to leave 15 for another day. But when we look at tooth number 14, and we're going to just orient the long axis of the scan along the long axis of the tooth. And here we can actually see, I'm just going to focus in on the axial section. When we look at this tooth, this mesiobuccal root, we can see it's an oval shape. And we can also see that we can see here that oval shape, and we see here that the root canal fill is deviated slightly from the center. The law of centrality dictates that any nerve and blood vessel that is responsible for the development of the tooth, it really has to be centered within the root. If you see it not centered, basically it's an indicator that there is another canal or an extension of that canal that is present. So we informed the patient that we suspected that there might be a portion of the tooth that might not have really been thoroughly debrided, and that it was very difficult to get in there. We do not impugn anyone's previous work, but that being said, certain teeth like this, which have very difficult anatomy, sometimes it takes a specialist to clean it out. So let's go back over to the x-ray slide. This is an image of the tooth when I first opened it up. Here we can actually see the orifice of the tooth. And, excuse me one second. Here you can see a circular orifice in the palatal, another circular orifice in the distal, and here you can see a circular orifice in the mesial buccal. This is the region of interest over here. What's going on over there? Well, let's take a look. As we go through sequential images of us cleaning up the tooth, you can see here the shape of the orifices becomes even more evident as circular. We had to clean up a huge amount of calcifications on the floor of the tooth that had not been properly removed. And here we can actually start to see the outlines of that MB2 starting to form over here. Third sequential image here, we can actually see those two orifice more fully opened up. And those two actually ended up joining. And you can actually now see the fully opened up shape of that canal, which again, much more ovoid than it was before. And when you miss that MB2 canal over here, you're really leaving a portion of the canal uncleaned and riding up along the lingual aspect of that mesial buccal canal that the previous practitioner thought was so well cleaned out, was a whole mass of organic material that supported an infection that allowed that infection to persist. You can also notice how much wider and how much broader the distal canal is than it was before. This really represents a well cleaned out canal. And when we look at the final radiograph and compare it to the pre-op, I think it's self-evident just how much more thoroughly a tooth can and should be cleaned out in order to eliminate the source of the infection. I hope you enjoyed this video. I hope you kind of took note of of what to look for when it comes to finding and locating these MB2 canals. The modern standard of care is really to find MB2 canals in virtually all your molars. Oftentimes they will merge into one canal like you saw in this video. In about 50% of cases you'll see it really present as two separate orifice. So if you're not finding two separate orifice in at least 50% of your cases, I want you to consider taking some continuing education courses or perhaps making use of your local endodontic specialist. Hope you enjoyed this video. Take care.